Hi, good morning everyone. Nice to see such a big full room, and I understand that you are dietitians and nutritionists, so I'm probably not going to say anything that's too radically new, but it might be put in a slightly different context. I know that many of you may not be fluent in English, so do tell me to slow down if I start to rattle off too fast. So what I'm going to do today is to talk to you about assessing nutritional status. And here you see two pictures. What do you see in those pictures? The picture on the left is a geriatric, an elderly patient with severe acute malnutrition, a hospitalized patient. The picture on the right is a very famous painting that sold a few years ago for about 15 million euros. But they both show something, or a couple of things that are quite important. Malnutrition. And what do you mean by malnutrition? Okay. And how is that manifested? And what is obesity? Excess adipose tissue. And why is that important?
Because it's endocrine tissue that produces a lot of harmful substances that impact on life expectancy and health outcomes.
Right, okay, you're definitely on the right road. Basically what those pictures are showing you are two different aspects at the two ends of the spectrum of nutrition, where you've got changes in structure. So on the left you've got reductive adaptation, loss of tissue, muscle tissue, etc. And on the right you've got an excess laydown of fat. So you've got a change in structure, but you've also got a change in function. Okay, they're functional changes as you get more depleted in undernutrition and as you lay down extra fat. So obesity is really a clinical condition that has adverse outcomes. You're getting increased risk of health. Okay, it's not that you're fat, it's that it is a clinical condition. So the important thing is that when we're assessing nutritional status, we have to think about the change in structure as well as the change in function. Okay? So this diagram shows you that diet will provide us with the substrates, and those substrates get stored in the body, or if we don't have enough in the body mobilizes them so that we can then meet our metabolic demands for membrane transfer, turnover, and mechanical work. So when we're talking about nutritional assessment, the point of it is to provide an objective quantitative measure. Now that word objective is important. Why do you think that's important? Is it helpful for me to have said the person on the right was fat? Does that tell you anything? Or the person on the left was thin? Is that informative to you? Probably not, because we'll all interpret what is thin and fat differently. So it's very important to have a way of measuring that is quantifiable and very objective, that it's clearly defined, because then we're all talking about the same thing, and can work out what the risks are of being in those conditions and what the interventions are that we may need to do to fix those conditions. Okay? Nutrition well-being is a catch-all phrase, so it can either be undernutrition, overnutrition, or some mixture of those two. It's a very generic term that we use. And so what we want to do with nutritional assessment is to get a sense, a good sense, by quantifying the status of individuals or populations. And those of you who are dietitians will recognize what you do with individuals, and those of us who work at population levels, will recognize the sort of approaches we use when we're dealing with communities or national level populations. And we need to make choices, because what we do at one level may not be the same as what we do at another level. So for example, with an individual, you might be able to do a 7-day weighed and measured dietary intake. It's not practical to do that at a population level. So the tools you use and the way you approach things differs depending on whether you're focused on individuals for therapeutic reasons or problem identification, or population reasons, which is more about prevention, health prevention, promotion of good health. So at the end of the day, we're engaged in a process of trying to work out, to identify risk or to diagnose malnutrition, or which is overnutrition or undernutrition, to decide what action we should take to correct the problem, and then how do we evaluate to know that nutrition has improved. Okay? So nutritional assessment is involved in all those processes. So why do we assess nutritional status? What are the different things we might want to do it for? Well, we might want to do it as quantitative, an objective quantitative measure of nutritional well-being, so at the individual or the population level, to get at incidence or prevalence rates of problems, okay? Whether it's obesity, diabetes, or something like that. We might want to do it for surveillance. So that is to assess the risk of a problem within a group of people. So for example, say in the UK, amongst children, the risk of anemia varies between 12 and 15% depending on which report one reads. And then based on that, we would work out what intervention can we do to reduce that anemia in children. So surveillance or monitoring the state of the population is important for taking action to correct the problem at a population level and to prevent the problem getting worse or expanding. Screening is done at an individual level to identify risk. So you would weigh and measure a patient or a person to identify whether they're at risk of overnutrition or undernutrition. And that's usually associated with then doing a therapeutic intervention, for example, if in that context. Then there's clinical management of the individual, where you might want to confirm a diagnosis of over or undernutrition, or you might want to identify the reasons for that over or undernutrition, or you might want to monitor whether what you're doing, what you've advised the person, if you've suggested that they change their diet or do more physical activity, whether that's actually having an effect on their over or undernutrition. Okay? And then obviously in research, it's important for understanding the link between diet, physical activity, and nutritional status. And example there was a very important area that's becoming more prominent is the one of, say, diet and cancer. So nutrition is very important in there. So basically, measuring nutritional status is at the heart of everything we do. So it's a really important area. But it's not that simple, because even if you have a classic deficiency, it just doesn't come like that, okay? The body goes through stages of adaptation. So you will start with dietary inadequacy, and then you will get a decrease in tissue reserves, although you're maintaining your circulating levels of the nutrients. And it's only when your circulating levels reduce that you know you've got depletion of at the tissue level and the functional level. And then when the functional pool is no longer working, then you're going to get your overt signs of deficiency or the problem associated with that nutrient. So to get it all, to understand all those, to identify dietary inadequacy, you need to have a tool. Whether it's your 24-hour recall, whether it's your food frequency, whether it's your food diary, whether it's your weighed and measured intake, you have to have a tool that can quantifiably estimate food intake or nutrient intake, energy nutrient intake. For reduced nutrient in the reserve tissue, that's actually very difficult to do, and you can't usually do it because it's not easy or ethical to get tissue biopsies unless it's an extreme case. You can get nutrients in the circulation through blood tests, but these will fluctuate independently of the diet. So for example, some nutrients are associated with the acute phase reaction. So in even a subclinical infection, vitamin A levels will go down, ferritin levels will go up, zinc can go either way. So you don't necessarily know if you're measuring status or a response to the infection itself. So it's not always simple just to take a blood test or read a straightforward blood analysis. For clinical signs and symptoms, you need to know what you're looking for. And often we don't get to those extreme cases. I mean, how many of you in this room would be able to identify pellagra, which is vitamin B1 deficiency, or beta spots, which is vitamin A deficiency? Because they're so rare, we don't see them. So actually they're easy to miss. Even clinicians miss them because they're not used to seeing them. So that's not that easy. So the changes when we get to that stage where we're getting changes in structure and function, we know we've got a really big problem, because that's the tip of the iceberg, and underneath that tip will be a large segment of the population that are moving towards that haven't reached there, okay? And it's the same with obesity. The overt obesity, we see the number that we have for prevalence. Those moving towards that who are overweight, at risk of becoming overweight, are a much, much bigger number. So, when you get that change in structure and function, it's already telling you a very big issue. And just to give you an example, a very simple example, this is vitamin A deficiency, where you go from at the top here, that's a replete person, and as they go down to increasing deficiency, you go through these different states. So you're going to get poor diet, poor stores, low circulating serum levels. You then get changes in the eye cytology, dark adaptation. That's the sign of clinical deficiency. And then you get damage to the eyes. And for each of those, we do have cutoff points to define the risk of having that. And those cutoff points are specifically for preschool children. And, the worst outcome is, of course, keratomalacia, which is, this is irreversible damage to an eye due to vitamin A deficiency. So obviously we don't want to get to that stage, because if we've got to that stage, it's pretty bad. And if I go back to the previous slide, you can see that down here, the identification of people with that, if 0.1% of the population has that level of eye problem, 0.1%, you've got a public health problem. Because that's telling you it is so, we've got such a situation that a few people have got this far, many more will be on their way to getting there. So having these cutoff points at the various stages for the different levels of indicators for deficiency is quite important. Okay. The next thing to consider is reference data and norms, but a big challenge is what do we mean by normal, okay? Reference value give you a range of values, okay? It's not a desirable, it doesn't say anything about what it should be or what the perfect level is. It's just simply a range of values that you find in a population, okay? And one of the important things associated with reference data is how they are constructed. How do we get these data? Does anyone know how we get these data? Yeah, and everyone, or some people, or?
Then they do cut off points, or the graph for normal people, and less than 7%, or greater than 10%.
I think you might be talking about how we estimate requirements, dietary requirements, rather than estimating the normal range for any micronutrient. So what we usually do is use data from apparently healthy people. But what is healthy? How do you define healthy? You may all be healthy, but you might have some condition you don't know about. So when we do these collect data to get at norms, we are assuming that we leave out those people who are clinically sick, because we know they're not healthy. But otherwise we're using apparently healthy people to establish our norms. And that's where this, the statistical expression describing the pattern of distribution in a population. So we will look at, we will also look at different populations, whether it's the elderly, whether it's children, whether it's men, whether it's women, and look at the distributions of the indicators for each of those, okay? But as I mentioned, you have to take into account other factors. There may be socio-cultural characteristics, as well as usual or typical. So for example, for a baby, what is normal? Is breastfed the same as bottle fed? You know, is their growth the same? Does it differ? So you have to be careful when references are developed or created, you need to be very clear about the basis for which they were done. The other challenge with setting references is that there are very few, we don't have ranges for all nutrients. And what you might consider an acceptable range in Spain might be different to what we consider an acceptable range in UK, because our populations are different. But equally important, the laboratory methods are different. So different labs will give you different results. So you need to think about all these things, okay? Because often there's no standard, there's no gold method necessarily for all nutrients. So if you've got different methods, giving you slightly different results. Not everything is black and white. So there's quite a lot of things to consider in there. Okay, assessment of status. What can we do? What are the different ways we can do this? Anthropometric, that's one, yes. Sorry? Yes, blood tests, laboratory analysis. What else? Sorry, clinical symptoms, absolutely. Yes, dietary assessment. Let's see what we've got. We've got all of those. The population indices you can use are things like infant mortality rate, lifespan, prevalence rates, growth rates, things like that are the population level indices. Dietary supply, how much food is produced, how much food is available. So those national level, the bigger picture statistics can tell you something about what people have access to per capita availability. It doesn't necessarily mean they eat it, but you know that the supply is there, that it should be enough to feed the nation. Someone's mentioned anthropometry, clinical science, which comes under physical examination, lab analysis, and then functional assessment. And we'll just talk a bit about each of those. So the heart of what I want to talk about today is that nutritional status is what you eat, so your diet, what you are, so your body size and shape, and what you can do, your functionality, okay? Metabolically and physically, how you can function. And so although we tend to focus on where we are today, we need to consider where has someone come from. That might be more relevant for clinical nutrition. And also, where are they going? So looking at risk factors for predicting health. And you've had people talk to you about obesity and chronic disease. So your status today can predict what will happen to you in the future, particularly in terms of the chronic disease. And for many of our governments, that is the big concern, the obesity problem, and the risk factors and the costs associated with the chronic disease in the future of having an obese population today. The simplest way to do this is to, of course, make a 3x3 matrix and to consider what you need to do to fill each of those cells. But in reality, we tend to focus on the what you are. This is what we tend to focus on today. We don't really pay enough attention to where you're coming from and looking enough at what it means for the future. So in terms of, if we look at what you eat, so the diet aspect, one of the things you have to be very clear about is what are you asking? What is your question? Why do you want to know about the diet of a person? Okay? Is the diet healthy, for example? Or is it related to some problem they have? Or is it something that at a population level, is it high salt, you want to bring it down? Is it too much hydrogenated fat, you want to see where it is and take it, get food industry to change that? Or do you want it to be that you're going to promote health to prevent, to get people to change their behavior and eat a better quality diet? So you need to be very clear what your question is in deciding how you're going to assess diet. And we have we measure dietary exposure in 3 ways. This is the conventional way that you'll all be probably familiar with. We look at what people eat, whether it's a food frequency, 24-hour recall, etc. From that, we use food composition tables to calculate energy and nutrient intake. We then look at requirements, and then we decide what the adequacy of the diet is. But there's some big assumptions in there. There's big assumptions that the food composition tables are right, It's a big assumption that we know what requirements are. That's a whole other lecture which I won't go into. And then there's also a big assumption that we know what adequacy is. So there's a lot of issues in there, although it looks quite simple. Our second option is to not so much focus on adequacy and inadequacy, but to look at dietary patterns. So the type of foods, the groups of foods that people are eating. And then we come up with a summary status. And that we do by collecting dietary data, usually in the same way, but we use a different way of analysis. It's called principal component analysis. And we come up with prudent scores. So you might have read some work about prudent diets. And that's where this is coming from. And then the third way is looking at food consumption as well as non-food factors. So here we're looking at food security. So food security is access, availability, and affordability of food. And how does that affect dietary risk? Okay? And that has to be context specific. So you might want to focus on the elderly, or young children, or manual working people, but it will be different for different populations. Obviously socioeconomic factors come in there, ethnic factors come in there in terms of ethnic diets, where they're cultural diets and they differ. So the factors that affect dietary risk will differ depending on the type of diet and what determines that. So in terms of approaches to assessment, you can do at the population level, use food balance sheets. Our governments produce these, FAO compiles them, look at food availability per capita, how much milk per person, how much meat per person, and get some estimate of whether there's enough. You can look at commercial diets, all these supermarkets, every time you check out in a till, all that data is going into a database, they know what you're buying. And you can analyze those data and look to see its shopping patterns and get an estimate of availability of nutrients based on people's shopping patterns. Tesco in UK do that all the time. You can look at a group household balance, so national surveys. We have a regular national diet nutrition survey in the UK, where they're looking at our dietary patterns and how dietary patterns change so that can inform policy. Inventories and recalls of foods in people's kitchens. And then the individual classical ones that as nutritionists you'll all be familiar with, so I'm not going to go into detail. Their strengths and weaknesses of all those, as you well know. And from food consumption, we can get information on eating habits, whether they're general or specific. Specific foods. We can get a sense of meal patterns. We can get a sense of what's available locally. And we can also get a sense of what is served and what is wasted. Okay, because what's put on a plate isn't always eaten, as you know. And that goes into a food composition database, and from which we get our energy and nutrient intakes. But as I mentioned, you need to be clear what your question is in deciding which method you're going to use and how you're going to use the information. Are you interested in an individual, or are you interested in a group? If you're interested in a group, you have to use a simpler, more feasible method, food frequency, for example, because it's practical. At an individual, you can use a more detailed method that requires more investment in time and people. Is it a self-selected sample? Do you put something up on the web and ask people to, fill in a form? Do I ask a group like yourselves, someone want to fill in this questionnaire and do it, or is it experimental? So is it a random sample? Is it a sample based on within a group, say with diabetes, if you're interested in diabetics, do you then take a random sample of diabetics? So you need to think of what it is you're asking. Are you interested in recent data? Recent diet or habitual diet. So what do you normally eat versus what did you eat? Okay? If if you're trying to look at dietary patterns? Are you interested in a single point in time of what are you eating now, or changes over time? Has the diet changed over time? You might need to look at longitudinal data, so periodic surveys, and collect the information that way. Are you interested in food intake or energy and nutrient intake? So do you want to know how many kilos of meat someone eats versus, protein intake, iron intake? So again, two different things. And your degree of precision, how accurate do you want your data to be? Again, that will influence your method, your sample. And then whether you want absolute intake or relative rank within a population. Okay, so lots of issues to consider when you're thinking about a dietary survey. So moving on to what you are, which is size and shape. Anthropometry, height, as you well know, measures length or stature. Length we tend to do on children under 2, just so that it's a standard cutoff, because if you're measured lying down, you tend to be a little bit longer than if you're measured standing up because of gravity. So you may have to do an adjustment for a length as opposed to a height. So we generally say under 2-year-olds we'll do them length, then we know they're all done the same way. And again, reference data. WHO has new growth data for children, and there are already existing reference data for adults. And then weight, which is obviously accumulation of fat and lean tissue, so that's the muscle, viscera and bone. And you can calculate weight for height and compare that against an ideal body weight, a perceived ideal body weight, and the BMI, which, as you know, is weight for height squared. And you can look at weight and height loss. And these are just pictures to show you measuring recumbent length is not easy. Lots of noise in that data. I don't know if any of you have tried to measure a 9-month-old baby who doesn't lie still. Even measuring standing up, a small child standing up, is not necessarily easy. And then weighing scales are different ways. These are the Salter hanging scales that we use in developing countries. Obviously, in developed countries, you can either put a baby on a scale directly, or you can have a mother hold the baby and tar the scale or set the scale to 0 when the mother's on it, and then she holds the baby and you get the weight that way. So there are different ways of doing it. Lots of issues with quality of scales, accuracy of scales, but that's a whole other area as well, and the need to calibrate your scales to know that they're accurate. Same with your height boards, the need to know that they're measuring what you think they're measuring. Have you seen this graph in the last 3 days? You have, so I don't need to go through it. Okay, the only thing that I do want to say is that the cutoff, it's about 27 when you start, BMI of 27, when you start seeing the exponential change in mortality against body mass index, and again below 20. But interestingly, we don't use that cutoff. We use the 25 and 30 just for expediency. This graph was originally designed as an actuarial study, and it was done by requested by insurance companies who were interested in the risk of death of overweight people, in terms of for their insurance premiums. And so this is when George Bray did this study. So it was actually nothing to do with obesity as to where this graph came from. It was done for insurance purposes. And so once this association became known, there was an interest developed into overweight and obesity, and a whole clinical profession developed out of this. And so the cutoff points are somewhat arbitrary. And that's important to realize that, you know, so the thing of obesity is not something that we recognize as being a clinical condition with long-term outcomes until, you know, until after this graph was developed. This work was done for a very, very different reason. And this is just to show you, as you know, that there's a big interest and concern about central adiposity, that's torso fat, visceral fat, which of course has higher risks associated with long-term outcomes. And so this is just a cat section across at the umbilicus. You can see the spine here, and this is all the visceral fat. This is in an adult male, which is a predictor of increased risk of chronic disease. And here are some data that you can see that the fatter, the bigger the belly somebody has, the bigger the waist to hip ratio, the increased risk of these conditions. And that's independent of how severe the obesity is. So you can see here the blue line, these are moderately obese people, and these are severely obese. So the trend is still the same, irrespective of how severe the morbidity is. How do we identify people at risk? We can use the malnutrition screening tool that tends to be used in hospitals. This is for underweight. And what that looks at is current BMI, recent weight loss. There's three components to that: current BMI, recent weight loss, and the likelihood of eating in the next 5 days. Very simple score, but very powerful for predicting undernutrition. Weight loss, mid-upper arm circumference, and mid-upper arm muscle circumference, which adjusts for the fat, and those are our standard formulae. And then overweight is BMI, waist circumference, or the waist-hip ratio, and weight gain. Looking at children, here is a picture of 3 children. Do you think they're all the same? Which child has a growth deficit? Who thinks it's the child on the left? Who thinks it's the child on the right? Yeah, it's the child on the right. Why is it the child on the right? Sorry? That's definitely not marasmus. That's definitely not kwashiorkor. They're the ages of the children. The child on the right, the child on the left, as you can see, is a 2-year-old, and he has a large head and torso in relation to his legs, because, you know, the brain and the organs are growing fast when you're little, okay? The child on the right, this is a normal 4-year-old. These two are normal. So the child, the 4-year-old, has normal body proportions. The child on the right has the normal head and torso proportion as the 4-year-old, but he's got short legs. Okay, so he's stunted. His growth is stunted. And that's usually due to poor weaning practices. So the transition from breast milk onto the family food, 6 to 24 months, he's had a poor diet, chances are. This child, that's marasmus. So that child has a normal height, but is too thin. A lot of muscle wasting, a lot of reductive adaptation. Okay? And this child, what do you think that child is? Is that child normal? No? What's abnormal? So he's overweight. So his weight is too much for his age? His weight is normal for his age, but he hasn't grown in height. Okay? And the reason for that is a poor quality diet. So he's getting plenty of energy, but he's not getting micronutrients. And so that's often, so a high-fat diet. So we have in the UK, for example, children that get fed chips and, a lot of rubbish, junk food, and they don't grow well because of that. Okay? And this was very typical going back 10 years or so in China, when they, particularly with the one-child family policy, you'd get these fat babies because of the poor quality diet. Right, how do we identify children at risk? We don't talk about obese children. We talk about overweight children and risk of overweight, okay? Because there is no clinical definition of obesity in children like there is in adults. Okay? So risk of overweight we can do by weight for length or weight for height or BMI for age. And if it's over the 95th percentile, then they're overweight. And the risk of overweight is a BMI between 85 and 95% of the centile. Undernutrition is the converse, but below 5%. Head circumference, of course, is an important sign of brain development. So if you've got a head circumference below 5th percentile, that suggests there might be some other problem, not necessarily nutritional, and that child would definitely get referred for further investigation. And then stunting and underweight and wasting. But you can have conditions where you're both stunted and wasting. As you know, growth is canalized, it's targeted and self-seeking, so there is a tendency to stay on that 50th percentile. And if you fall outside, below the 5th percentile or above the 95th percentile, you're at risk of poor growth. And where we identify children who are not growing well is whether they're outside those measures or whether when they're growing they cross percentiles. So they don't stay on their growth trajectory, they start sliding off. That is a sign that the child is not growing well, there is a nutritional problem, you need to do something. And that's why we do growth monitoring of children, because it's a fairly simple way of picking up children at risk, whether it's overweight or underweight, and whether you need to do something about them at an individual level or at a population level. So for example, in the UK, where we measure all children in reception year at school, so 6-year-olds and 10-year-olds, and those data are collected every year by schools, so we're tracking growth or prevalence of obesity in particular, and that number is going up. And so the government is now busy trying to work out what interventions can we put in place to curtail that continual increase in obesity amongst these children. So that's a way of growth monitoring, but at a population level with 2 points in time. That's for slightly older children. So looking at, as I mentioned, there's children can be both growth wasted and stunted. So this is a normal child. You can get a child with a normal height who's thin. That's a wasted child. You can get a child who is short but a normal body weight, so that's, a stunted child, and you can also get a wasted and stunted child. Okay, so this is how we classify children. This is a Waterloo classification system. We usually use either the percentile cutoffs or the Z scores. And the challenge is to pick up these differences and when they're occurring. Turning now to body composition, there are lots of ways to characterize body composition, and you can get at body fat, lean tissue, and water. And the ways we can do that, starting with the indirect, doubly indirect is skin fold thicknesses or bioelectrical impedance. Do you know what that is? You're familiar with bioelectric impedance? Okay. The indirect methods, density or total body water, and the direct method, which is the gold standard, the best way of doing it, which is deuterated water. So these are just pictures, I'm sure you've seen them, underwater weighing, bioimpedance, and the bod pod, which is a good, it has, correlates very well with the underwater weighing and skin fold thicknesses. Then looking at physical examination, what you need to ask is what are you seeing and whether it's normal. What's the time? It's 10. 5 to 10, okay, thank you. So you can see physical signs, the hair will become brittle, the skin will slough off and it doesn't get replaced if you're malnourished, your generation of new cells is affected, your nails become brittle, sunken eyes, you're dehydrated in behavior. Undernourished children are not happy children. And then if we look at what we can do, which is the functional side of things, this picture just shows that this is something that's been going on for centuries. This is a picture from the 1600s, looking at a urine sample for cloudiness, and that was the forerunner of clinical pathology. So we can, if you remember that first picture I showed of the stages of going down depletion, that internal changes will happen before you get to overt clear signs. You can look at different biological tissues, plasma cells, you can also look at sweat, saliva, feces, urine. Again, the need for reference data, but as I mentioned before, blood levels may not reflect stores, but they can reflect recent intake. You need to, and this relates to that last point, that you need to consider whether there's infection or trauma or disease or any drug interaction that might be going on that could affect a biochemical marker for a nutrient. And obviously having more than one measure is better than having a single measure. Then the last bit in measuring function, you can look at energy metabolism and substrate utilization, so indirect calorimetry using respiratory quotients. You can look at functional capacity, put people on a treadmill, see how they change the inclination or the speed, and see how they perform, measure oxygen output, VO2, and things like that. Mood states, which is measured by perception of mood states, which is how people feel or think they feel. And that's quite good. It's particularly good in children when they're sick. Or you can look at renal, hepatic, gastrointestinal function. Those can be done by lab tests or tracers. So my final slide is what we need to do to assess status is at the population level. do surveillance where we look at nutritional risk and we use that to develop policy. We need to look at what we are, what we can do, and what we eat at a population level. Screening at the individual level is for the body component parts, so weight, BMI, waist circumference. We can do those fairly easily. And then when you have an intervention, you need to monitor the change in what people have eaten, what they are, how their nutritional, their physical nutritional status is, and in their change in what they can do, any metabolic changes that go on. Okay, thank you.